Right, you guys, we're going to be talking about anti-infectives in this module review. I want to start out by saying if I use the word anti-infective or antibiotic or antimicrobial at different times, pretty much used interchangeably in healthcare today. There are some slight subtle differences in those terminologies, but they're used interchangeably across the board today. So I don't want you to get hung up on that. These agents have been around since really the 1930s and 1940s, and they've greatly reduced morbidity and mortality that's caused by infection. We're continually developing new because as fast as we develop them, these bacterial pathogens are developing resistance to what we have. So there are certain criteria that we always want to be looking at before we choose an antibiotic for a specific pathogen. And we'll talk about why that's so important here very, very soon. So some of the things that we want to consider when we're choosing an antibiotic would be the chemistry, which would refer to the subtle differences in the chemical structure of both the, I would say, both the antibiotic and of the pathogen that you're trying to kill. Okay, and we'll talk about what those would be. But these can alter the spectrum of activity, distribution in the body, toxicity, and likelihood of resistance. When we talk about the spectrum of activity, that would be really big generalizations. Say drug A is generally effective against gram-positives, but there would always be some exceptions there where you couldn't say that this type of antibiotic was always successful in treating a certain classification. Mechanisms of resistance would be the way that the pathogen develops immunity can circumvent resistance to the drug. Toxicity here, toxicity is in relation to the side effects that a drug might cause, or how potentially what's the word? How deadly it is to not only a bacterial cell but to a human cell. Administration, oral versus parenteral. This could be how many doses do we give daily. This is important to consider because it might affect patient compliance, frequency of hospitalization, and the cost of treatment. And then distribution. Distribution meaning how does that drug get to the cell that we're trying to target, okay? Drugs must reach the microbes to be effective, right? So we have to know which drugs would penetrate, say, the blood-brain barrier or choroid capsules, the eye, abscess walls, which drugs will get killed in the GI system or which can pass through, which drugs are more likely to be effective in the urinary tract. Those are all very, very important considerations when we're choosing an antibiotic. So when we're trying to find an effective treatment for a pathogen, it's very helpful to take these pathogens and separate them into specific classifications. And we do this by both the method of action and by their structure. So when we're talking about structural characteristics, we'd be talking about the cell wall, gram-positive, gram-negative, its shape. Is it rod-shaped bacilli? Is it the spherical cocci? Is it the spiral-shaped spirilla? And then the method of action could pertain to its need for oxygen. Is it aerobic? Does it need oxygen to go through its DNA and RNA cycle as it regenerates and grows? Does it not need oxygen to do that? So one example of how we might use that would be, say, gentamicin, which is an aminoglycoside. And that type of antibiotic gains access to bacteria by an oxygen-dependent pump, then binds to a ribosomal protein that's unique to that bacteria. And so if we knew that, would we use gentamicin for a bacteria that was anaerobic? Well, no, it wouldn't be effective at all, right? If we're trying to target if we're trying to stop the process of pathogen using oxygen to replicate, then it would do no good if we tried to use it for bacteria that didn't use that process. So, and remember, when we're talking gram-positive, or when we're talking cell wall classification, the gram-positive bacteria are the ones that have the thick layer of the peptoglycan on it, and that when we put it in the gram stain, it turns purple. Those are actually easier to treat because that cell wall, that thick layer of the peptoglycan, actually will absorb antibiotics into it, which helps us destroy certain pathogens much easier than we could a gram-negative pathogen. Okay, so this slide shows some of the mechanisms of action with antibiotic drugs. These might inhibit the cell wall synthesis. It could activate enzymes that disrupt the cell wall. It could weaken the cell wall. It could promote bacterial lysis and death. It might increase the cell membrane permeability, which actually would cause the insides of the cell of the pathogen to leak or burst. It could affect the DNA and RNA or disrupt that function, which means that it would stop growing, or it could seriously slow down that growth. When we talk about these methods of actions with these antibacterial drugs, they might be talking, or they might be classified as either bactericidal or bacteriostatic. So the bactericidal, those will actually cause death, cell death to the pathogen. The bactericidal are lethal. Okay. The bacteriostatic, they typically slow the bacterial growth but don't cause cell death. And we use those. Those can be very effective as it lets the body's immune system take over and attack and kill on its own. Okay, so just a little bit of additional terminology when we're talking about anti-infectives. So when we talk about selective toxicity, this would be the ability of the anti-infective agent to kill off the pathogen. And we want to do that very specifically without damaging the host cells around it, without killing any healthy tissue, right? Or without killing off any of the good flora. We want to be as specific as we can with whichever antibiotic that we choose, making sure that it's going to work and it's most appropriate. When we talk about acquired resistance, that's the ability of the bacteria to change over time. That usually happens over time, where the bacteria get to look at certain anti-infectives, and if it's not killed off all the way, it actually can mutate, changing itself slightly, or different bacteria can shed and share DNA with each other, which is conjugation. It doesn't really matter how it happens. It just, the end result is that an antibiotic that was effective at one point loses its effectiveness. When we talk about nosocomial infections, that just means it happened in the hospital. The patient didn't come in with that infection. It's hospital acquired, health community or healthcare associated. They all mean the same thing. When I think of a nosocomial infection, the one that comes to mind fastest would be like a UTI that's caused by a catheter in the hospital. Another really, not popular, but common one would be C. diff. I don't know if anybody, if you've worked with C. diff, Colostrum difficile, you'll know that was caused by us killing off the healthy flora, right? And it lets the bad bacteria run rampant. A yeast infection it could be a hospital-acquired infection. Pneumonia is a big one. Pneumonia, especially for a patient that's like on a ventilator or something, where bacteria can be introduced through that oral airway. When we talk about culture and sensitivity, this is how we determine which antibiotic will work best for which pathogen. And we collect a sample. It can be sputum, it could be blood, it could be urine, even in the stool, and we send that down to the lab. One of the most common would be to do a gram stain culture, or they might do a culture where they let it grow out over 48 hours to see if more bacteria grows in that sample. And then they'll do a sensitivity test with different elements to see which antibiotic is most effective for that before we introduce it to the patient, because if we don't do that and we're using broad spectrum antibiotics routinely, then we are really contributing to the problem of acquired resistance. I do want you to note, and you might be tested on this somewhere along the line, that you always want to obtain your culture before you start any antibiotic therapy. It has to be done first before antibiotics have been introduced, or it will skew the test. Okay, a superinfection is defined as a new infection that appears during the course of treatment. Again, a really good example of this would be like a yeast infection that happens in the hospital, or C. diff would be a great example of a superinfection in the hospital. MRSA. That could also be, you could also think of MRSA when you think of acquired resistance. That would be methicillin-resistant Staphylococcus aureus, where it just doesn't respond to that antibiotic anymore. We have to go a lot stronger, broad-based, usually Vanco, for something like that. So peak and trough would be testing to see, we're looking for therapeutic levels in the blood. The peak would be at the height of the dosage, and the trough would be at the low end before more medication is needed. Again, I think of Vanco when I think of a peak and trough, and it almost always is a trough. We're almost always testing at the lower end and not the high end. Prophylactic therapy, that would be where we are giving antibiotics to stop an infection before it starts. When I think of prophylactic therapy, I think of a surgical procedure. Maybe you've got a patient that's going in for a total knee replacement. It's really common that they would start antibiotics first, even just one dose. There's a whole bunch of other procedures where that could happen. But just remember that prophylactic means that we are trying to stop an infection before it ever starts. So our first classification groups will be antibiotics that affect the bacterial cell wall. So these would be bactericidal. Okay, and that would include penicillin, cephalosporins, carbapenems, and then you've got miscellaneous cell wall inhibitors, and we'll talk about vancomycin with that. So before we talk about that, it's just important to remember that the cell wall, the outside of a bacterial cell, is made up of a rigid, permeable mesh-like structure that it holds all the stuff inside with a really high degree of osmotic pressure. And so if we compromise that outer structure, it will cause cell death, lysis, which means disintegration, and then ultimately cell death. For penicillin, a good explanation would be where it weakens that cell wall and it takes up excessive amounts of water, and it causes extra pressure, and it causes that cell, that bacterial cell, to burst. They don't all work in exactly the same way, but just remember that they all will cause some destruction to that cell wall, causing lysis and then cell death in some way, which will kill off the bacteria. It will prevent it from growing and spreading, right? Okay, so first up is penicillin. Remember, this is a cell wall inhibitor. It is bactericidal. It is effective against most gram-positive and some gram-negative pathogens. Penicillin was really the first antibiotic that was mass-produced, and that was back in the 1940s, and we used it. I was not born in 1940, but they used it for everything. Okay, everything, colds, flu, upset stomach. Let's give penicillin. It just seemed to cure everything. It didn't really, but it was so new and novel and worked so well on the things that it should that doctors just started prescribing it. And because of that, we have seen it lead to a development of resistance against many strains of bacteria. So we now use it in a much more narrow spectrum view. Some penicillins, like we'll talk about penicillin G because that is your prototype, is considered to be a narrow spectrum antibiotic. I want you to note somewhere in here that it may inhibit the effectiveness of oral birth control. Antibiotics are generally safe for women that are taking the pill, but penicillin, for whatever reason, seems to inhibit the effectiveness of the birth control. And so if you've got a woman that needs to take this, just really caution her to be using another form for like that month's cycle. Okay, write that down somewhere. Some of you are going to be tested on that, I'm pretty sure. And then another thing I want you to know is we want to assess for allergies for penicillin because while it's considered one of the safest antibiotics, meaning it's the least toxic of all antibiotics, and remember when we talk about toxicity, we're talking about danger to healthy host cells, but it also is the most common allergy of all medications that are prescribed, not just antibiotics, but it's the most common drug allergy is associated with penicillin. I mean, up to 7% of patients who receive penicillin experience some sort of allergic reaction. Usually it's very mild, and it might cause some fever, it might cause a rash, could be common, but it could be very life-threatening, a case of anaphylaxis as well. And so we always want to assess if you have penicillin show up on a drug list, or if you have a patient that tells you that they are allergic to penicillin, your first question should be, what was your reaction? We want to know how significant that was. Okay, if you've got a patient that has an allergy to penicillin that was severe, we want to avoid giving them a cephalosporin as well. Even though that isn't the same classification of medication, there is about a 1% chance that a patient that has an severe allergic reaction to penicillin will experience the same with a cephalosporin. So that's something that we will want to know. Some other adverse effects that you might see with penicillin could be nausea and vomiting. It's not nearly as common, but it does happen. Diarrhea could happen. If you're giving penicillin and your patient starts to experience diarrhea, you need to be watching for signs of C. diff because it's more common there. It might also cause lethargy, some hallucinations, confusion, seizures. Again, those are not very common. When we talk about allergies to penicillin, generally we're talking about a rash. And that could happen right away, and it could be delayed up to 2 or 3 weeks as well. And so just be aware of that when you're doing your nursing assessment. So I should mention when we're talking about the classification of penicillin that this would include other antibiotics that end with "-cillin", like amoxicillin or ampicillin. And these are very, very frequently prescribed for problems that deal with the ears, nose, throat. If you've had kids, you've probably given amoxicillin to your child for ear infection, say, or strep throat is very, very common. So just keep that in mind, that those would fall under the same classification here. So here's some nursing considerations with penicillin. We want to administer this at least 1 hour before other antibiotic classifications because it could inhibit the bacterial cell growth or decrease the rate that penicillin, it just decreased the efficacy of how penicillin attacks that cell wall if it's given with other medications or other antibiotic classifications. Okay, it should be given 1 hour before or 2 hours after meals, and this is penicillin. Some of the others, like amoxicillin, can be given with food or without. So we're talking about primarily penicillin G with these nursing considerations. If it's an oral suspension, it should be refrigerated, and you should shake it well so that it mixes, so that you're getting the right dose in each administration. IM injection should go into a deep, large muscle. So we're talking about like the gluteus maximus there, into the thigh would be good, the bigger thigh muscle there. And you should rotate that injection site to minimize tissue injury. Also, applying ice will help reduce swelling. And we should never inject more than 2 grams of drug per injection site. And that's pretty much any medication that you're giving IM. With IV infusions, don't add or mix another drug. This would mean either mixing it in the bag with the penicillin or weighing it in at the end. It shouldn't go into the same injection site. So if you have a primary drug running and you need to give penicillin IV, you should stop the primary drug while you administer the penicillin. We always want to be looking for allergic reactions continuously while your patient is taking this, and watch for signs of super infections. And watching for signs of super infection should be a nursing assessment no matter what kind of antibiotic you're giving, especially if your patient is immunocompromised or is taking any immunotherapy type drugs where their immune system response is already inhibited. We go and clear out the good bacteria and the bad bacteria is just going to go crazy. And this is when we would see increased maybe thrush in the mouth or yeast infections. I know with little kiddos, it could be common, especially for babies, to see yeast infection in the diaper area when they're taking something like amoxicillin. Monitor for hydration status if GI symptoms occur. So if you've got a patient where this antibiotic is causing nausea, vomiting, diarrhea, be assessing hydration. And remember what you would be doing to assess hydration. Be thinking of that in your head. Okay, so our cephalosporins are beta-lactam antibiotics, and they're very similar in structure to penicillin. They're bactericidal, and they're active against a broad spectrum of pathogens. Their toxicity is really low, so that makes them a very popular choice. It's probably our most widely used group of antibiotics. They don't attack the cell wall the same way that penicillin does. It's similar. They're both bactericidal, and they both weaken the cell wall structure, but cephalosporins bind to the penicillin protein site within the cell wall, and what happens is when the cell tries to regenerate and it's splitting off into its two sister cells, this cephalosporin, when it binds to that protein, it prevents the cell wall from closing off. It leaves a hole, and so the contents leak out, and it causes lysis and death. Okay, so we classify cephalosporins by 5 generations. The first generation drugs have the most gram-positive coverage, and the later generations have the most gram-negative coverage. We can find anaerobic properties in the second generation drugs. Some of them, I want to say the third generation, which would be Rocephin, can cross the blood-brain barrier, which makes it highly effective against treating meningitis. So again, you won't be tested for that kind of stuff, but it is important to know that each generation has different attributes, which makes it more effective for different pathogens. Our cephalosporins share many very similar common adverse effects with penicillin, including that diarrhea and rash. And we can have that cross sensitivity, like I mentioned, with penicillin. So we always want to ask our patient if they have a sensitivity to penicillin. I know I stated that penicillin cross sensitivity can occur in 1%, and I think that's a pretty good average. But as you do any reading about this, some will say 1 to 4%. One of the textbooks said 6%, and one of them actually said up to 16% of people that have penicillin allergies will have a reaction with a cephalosporin as well. So we always want to assess for that. They're nearly identical with penicillin in the therapeutic effects and in adverse reactions, so I'm not going to go over those. Again, just your nursing considerations will be very, very similar. So some of your cephalosporins would be, they all have ceph in them, like Rocephin. Well, that's a brand name, like ceftriaxone or cefazolin is a very, very popular one. You've heard of Ciclor or K-Flex. Anyway, those are all cephalosporins. And what I really want you to consider and remember is that cross-sensitivity with penicillin. Carbapenems have the broadest antibacterial action of any of the antibiotics that we have to date. And for this reason, they are primarily reserved for serious or life-threatening infections. They work by inhibiting cell wall synthesis. They are bactericidal. Um, and again, we primarily reserve these for complicated cases that are in the hospital, such as body cavity infections or connective tissue infections, bacterial meningitis. It's often used for that, or nosocomial infections that you might see in the hospital. One hazard that we want to know about carbapenem, they do have a lot of the same adverse effects that the other antibiotics do, and you certainly would want to be assessing for those super infections and for the nausea, for rashes, things like that. But they also carry a high risk for seizures and can cause hypotension and hyperkalemia and respiratory distress and even death. I won't say that that's really common, but certainly you would want to be assessing or taking some seizure precautions with patients that are getting carbapenem. So think in your mind, what would I do if I had a patient that I thought might have a seizure? What would I do proactively to help keep that patient safe? Be thinking of those things, because those would be nursing interventions or nursing actions that you should take if you've got a patient that's taking a carbapenem. So these would include meropenem, etrapenem, and imipenem celastin, which is a combination drug, and those are always given together if you're giving imipenem, because the tubules in the kidney, it's metabolized very rapidly there, and if you didn't combine it with the celastin, it would just be totally ineffective. So I think that's really all you need to know for this purpose for carbapenems, but just keep in mind that we do have those extra nursing assessments that we should be taking, or precautions that you want to be aware of. Vancomycin is a bactericidal antibiotic, and it's in the glycopeptide class. It destroys bacteria by binding to the bacterial cell wall, which produces an immediate inhibition of the cell wall synthesis, leading to death. So very similar to the action of penicillin, not in the same way, but it has the same result. It is the antibiotic of choice for the treatment of MRSA and also for C. diff. It is also very effective in treating bone and joint infections, bloodstream infections. We would give this for somebody that was septic. We would give it for MRSA. We would give it for cellulitis, especially if it was caused through the bloodstream. It has been associated with more frequency lately in a resistance. We call it VRE, which is vanco-resistant enterococcus. It's contraindicated in patients that have a known hypersensitivity, and it should also be used with caution in those that have pre-existing renal dysfunction and hearing loss. It does contribute to renal problems, and it is known as an autotoxic drug. So with that said, before you give this, you would want to be looking at your patient's latest labs, right? Assess their BUN and their creatinine before you ever give it, and then certainly be watching those during through the whole administration period. You would also want to be assessing their hearing capabilities, any hearing loss, to see if that exacerbates it or gets any worse or not. It's hard to assess hearing if you don't know what their baseline is, right? We also want to be monitoring. This is where we're looking for the trough levels, and we'll talk about that in just a second. Vancomycin, one of the most common adverse effects that you'll hear about, and it's really bothersome. It's not usually harmful to the patient, but it's known as red man syndrome. It's characterized by flushing or itching of the head, face, neck, upper trunk area, and it's really interesting to see, but you'll usually see it about the nipple line and above, and it's like a nice straight line. It's not like kind of patchy. It's like a line that's drawn, and they are red up. It's generally caused by infusing vanco too quickly, and so what you should do is just start the infusion, especially if it's a first-time dose, just start it slower than it's been ordered and monitor that for, 10 minutes or so and see how the patient tolerates that before you increase it to the rate that your doctor has prescribed. Vancomycin is usually determined by the patient's weight, and with most infusion pumps in a hospital setting, it will ask you for the patient's weight by kilogram, and then it will calculate that dosage for you. Many physician orders will tell you the rate to give it to, but I find that a lot of times the pumps will have you run it a little bit slower than the doctor has ordered, and I think that's always a really good practice to do initially to make sure that they tolerate that okay. It does run slowly. Typically a gram will not run any faster than over an hour. Anything more than that, you could expect this to run for an hour and a half up to 2 hours. We do check the trough, looking for therapeutic levels, because this is a medication that if we're giving too much, it could be harmful, it could be toxic, and so typically when we're looking at a trough, it's generally ordered before the 3rd dose, and then before every 3rd dose again after that. But just check your hospital's policy protocols and make sure that you know before you give a dose where you are on that last trough, so that you can get it ordered before pharmacy sends you your next bag mixed, because they'll mix that bag depending on what the lab level shows, if that makes sense to you. I want you to always be assessing the IV site. Vanco can be necrotic to the tissue, and so with extravasation there, you'd be assessing for warmth and redness and pain, leakage, things like that. Again, it can affect hearing loss and renal function, and it's really important that you note that. That's a very popular testing question with Vanco, is assessing hearing and renal. Same thing with gentamicin, if you can think of those two. That's really it for Vanco. You'll give it a lot if you work bedside in a hospital setting, so it's just best that you become familiar with the practices for giving that and some patient education, especially regarding the Redmond syndrome. Just let the patient know if this happens, this isn't, it's not emergent, but you would definitely want to report it, stop the infusion, let the prescriber know what's happening. And most likely they'll tell you to just run it slower, but that is a reportable incidence there, so keep that in mind. Tetracyclines provide a broad spectrum of activity, and they cover a really wide range of organisms that include really everything: gram-positive, gram-negative, aerobic, anaerobic. They target things like spirochetes and the mycoplasmas, the rickettsiae and the chlamydiae, and some protozoa. They're used to treat some really fun problems like gonorrhea and chlamydia, Rocky Mountain spotted fever, Lyme disease, things like that. But we also use it to treat things like pneumonia or intra-abdominal infections, soft tissue infections. It's pretty common. It's commonly used in lower doses to treat acne in adolescents or, teenagers, early adulthood. It is a bacteriostatic antibiotic, which means that it slows down. It slows down how fast it replicates, inhibits the replication. It doesn't cause cell death or anything like that. It just really slows down how quickly it can, how quickly these organisms can grow, which lets the immune system do its job better. Some of the side effects that are associated with tetracycline would be nausea, diarrhea, hematologic disorders, Stevens-Johnson syndrome, which is it's a rare, serious disorder of the skin and the mucous membranes. It's pretty rare, but it can be life-threatening. It usually requires hospitalization if it does occur, and it can happen up to 2 weeks or so after taking tetracycline. So just know that presents as it looks like a really serious sunburn that would have like blisters all over it, kind of a deep purplish red, and it can start to peel, and it can be inside the mouth as well. And it's typically treated in a burn unit when it occurs. It can present as a regular allergic rash with other hypersensitivity reactions. So I do want to point out the photosensitivity that I have here on the slide. That's a really popular NCLEX question in relation to tetracycline, is that it causes photosensitivity, and so you should be teaching any patients taking it to be wearing lots of sunscreen and to be staying out of the sun, or if they're outside, to be in the shade as much as possible. When I was in nursing school, I actually learned to remember this by there was a picture of a little character that was on a tricycle, and they had on tons and tons of clothes, like scarves and sunglasses and everything, and they were holding an umbrella while they rode their tricycle. And so just the tetra and the cycline, tetra meaning 3, and the cycle, and picturing them all covered up, just I'll never forget that they need to be wary of the photosensitivity, because it could cause discoloration of the skin. Also, it should be avoided in pregnancy and in children under 8. It does cross the, if you've got a mom that's nursing, it will come across to the baby in the breast milk, and this can be dangerous because, well, in a pregnant mom, it can cause, it can retard fetal skeletal development if it's taken during pregnancy. And it can also lead to discoloration of the permanent teeth and the tooth enamel in both fetuses and children that are under 8. And so they just really, really try to avoid it in these younger kids because of that. I've got on there to be wary of dairy, and that's just to remember that it can bind to protein in milk products, which would stop it from working. It would stop the absorption in the body if it has bound to the proteins in milk. So we typically, and not all tetracyclines do, they all do except for doxycycline and minocycline. And so in general, we just suggest that these are given 1 hour before or 2 hours after meals. Really, that's it for tetracycline. Just really try to cement in your mind that the photosensitivity factor, and avoiding it in pregnancy in these children under 8, and why the teeth discoloration and the bone formation problems. All right, gentamicin is an aminoglycoside. It's bactericidal, so remember that's going to cause cell death. We use it to treat serious infections that are caused by susceptible organisms. It's particularly effective in treating gram-negative bacilli organisms. That would be things like E. coli. It's also very commonly used with vancomycin when treating some of the, like strep or Staphylococcus aureus, things like that. I want you to cement in your mind that this is one of the other medications that is ototoxic and nephrotoxic, especially if it's given with Lasix, because Lasix is nephrotoxic on its own. So when you pair those two up, you've got a much, much higher risk. So if you've got this risk of ototoxic, and this hearing loss can be permanent, so it's something that you should take very seriously. You're going to want to be monitoring that patient before you give it and after to note any changes, and then obviously be watching their lab values, be watching their BUN and their creatinine, and if those start to show some renal insufficiency, that dosage will probably be lowered. This is one that you might be asked to take a peak and trough with, especially if they're getting it 3 times a day, which is the traditional dosage. A peak would be taken 30 minutes to an hour after administering, and a trough would be taken just right before the next dose. It is also commonly used to prevent endocarditis, so that would be a prophylactic use of it. And it's also used during GI and GU procedures and surgery. So really the biggest thing I want you to remember about gentamicin is its ototoxic and its nephrotoxic tendencies. Okay, and then just some basic, really generalized patient education that really pertains to any antibiotic therapy that your patient might be using. Really stress that they need to take their medication exactly as it's prescribed, at the right times during the day, the right dosages. They need to be taking it through its entirety. They need to know if they need to take it with food or does it need to be on an empty stomach. Does it have any food interactions? Things like that. These two things are the biggest factors that contribute to drug resistance with antibiotic therapy. They should be reporting any adverse effects. Certainly teach them what the signs of anaphylaxis would be, what they should come to the ER for, what they should just have a phone call for, that they, what if it's mild, that they would want to keep taking it and call the doctor's office right away. If it were serious signs, that they should stop it abruptly and report to the ER. Certainly you should provide a list of foods that might prevent superinfections. So this could be probiotics, could really cut down on the risk of developing, say, a yeast infection. Things like that is always good patient education to provide. And then they should be reporting all medication allergies. And if they've had any high risk, anaphylactic activity, they should be wearing an alert bracelet, really at all times. Okay, so rifampin is a bactericidal macrocyclic antibiotic therapy that's used in the treatment of tuberculosis. It is widely distributed and it penetrates the CNS, and it's excreted through the liver. Rifampin, you should expect rifampin to be given with other medications, and it's important that you educate any patient that's got tuberculosis that their therapy will typically last up to 24 months. Okay, this is very, very critical that they understand the significance or the importance of adhering to their drug regimen very, very closely. They should be taking all of their medications exactly as prescribed. They should be taking them on a very, very strict schedule, because maintaining a steady blood level around the clock is critical to minimizing the chances of resistance to drug therapy. The reason that you should expect a patient to be on multiple drug therapies for TB is because there is a really high propensity for the bacteria to develop resistance to just one drug, and so multiple treatments are generally used, very standard. You're going to want with rifampin to be monitoring hepatic function very closely. So you want to educate your patient to be reporting things such as fever, nausea, vomiting, loss of appetite, jaundice, and or unusual bleeding, because those might all indicate the possible occurrence of adverse effects such as hepatitis or other hematologic disorders. Really, really stress the importance of follow-up appointments for any patient that's got tuberculosis, so that the therapeutic levels can be monitored and treatments can be changed as necessary. And also, if they live with family, their family members should receive some very thorough education as well, and they might need some prophylactic therapy for up to a full year for themselves, because tuberculosis is very, very contagious. It's an airborne bacterial pathogen that, it can stay in the air 3, 4, 5 hours at a time, many feet away. And so if you've got a patient that's got TB, they should be taught how to to wear a mask if they can, to cover their mouth when they cough, to be washing hands constantly, things like that. It should be avoided with certain medications, and the list is pretty long. You don't need to memorize this, but it would include things like antacids, phenytoin, carbamazepine, beta blockers, benzodiazepines, anticoagulants, anti-diabetic drugs, oral contraceptives, There's a few other as well. Um, for oral contraceptives, it really, rifampin is known to make oral contraceptives not effective at all. And so really they should be doing something else. And it wouldn't just be for the monthly cycle, right? And they're probably going to be on this for a year or two. And so they should be looking at other forms of birth control if possible. Really educate your patient that they might experience red, orange, brown discoloration of the skin, sweat, tears, urine, feces, sputum, saliva, and tongue. Really any bodily fluid could be discolored. It generally reverses when they discontinue taking the drugs, but if they don't realize that, that could be very disconcerting when you think to suddenly have orange tears. It can be orange enough that it would stain their contacts, things like that. So just make sure that if you've got a patient taking this, that they are expecting that, and just let them know that that is normal and that's not a reason to discontinue taking that medication. So when we talk about fungus and being treated with antifungals, we're talking about molds, mushrooms, yeast. These can exist on the body as normal flora. In fact, we all have it on our body in some degree as normal flora. And when we have anybody that's immunocompromised, or we're giving certain medications like, corticosteroids or antibiotics, we always risk causing a superinfection kind of event. And that's what we would be talking about here with these funguses. So they can range from just being annoying and itching, a little bit of a rash, to life-threatening if they're systemic. Systemic infections can cause death. So we want to kind of differentiate what's the difference between something that's systemic as opposed to what's the word? Superficial. A superficial fungus would just be on the skin. Maybe just in the mouth, on the tongue. Maybe there's just some yeast under the folds or under the breast or something, where systemic gets into the bloodstream and goes through everywhere in the body. We can treat these funguses with topical, oral, or parenteral preparations. They are classified as either fungistatic or fungicidal, and that would be very much the same as the bacteriostatic or bactericidal, where we're either inhibiting the growth or we're killing, we're causing cell death to the fungus. These can be acquired either community or nosocomial. The community would be by coming into contact with something. Nosocomial would be considered opportunistic, like the superinfection type of scenario. And we treat them superficially, so that would be like a topical cream, subcutaneously, or systemically, which would be a parenteral preparation. We also can give this orally. The potency of amphotericin B has made it the most widely used antifungal drug for severe systemic fungal infections. We use this only for very severe infections, okay? It's widely distributed throughout the body. It is a fungistatic medication, and it is highly toxic, so we use it under very close medical supervision. It's excreted by the kidneys, and it works by binding to sterol, which is a lipid in the fungal cell membrane, and it inhibits the multiplication of the fungus. It can become fungicidal with really high doses. Like I said, it's used to treat severe systemic fungal infections and even meningitis that's caused by fungi that's sensitive to this drug. We very, very closely monitor patients that are getting this. Okay, we give it IV. There are a lot of significant interactions that might happen with this drug, and a lot of medications that it should not be given with. such as aminoglycosides or cyclosporine, acyclovir, corticosteroids, penicillins, digoxin. They all could worsen. If it's given with digoxin, it could worsen hypokalemia or low blood potassium levels. And so again, this is something that we would monitor very, very closely. Some adverse reactions associated with amphotericin B would be chills, fever, nausea, vomiting, anorexia, muscle and joint pain, and indigestion. Because hypomagnesemia and hypokalemia can occur, you would want to have this patient on EKG monitoring and be watching for changes. And also you would want to really be watching their electrolyte panels in their BNP or the CBC, or in the CMP, whatever it is that you're having ordered. Magnesium and potassium levels and renal function should be very, very closely monitored. Up to 80% of patients might develop some degree of kidney toxicity, so you would want to be looking for changes in their BUN or creatinine, be monitoring their urine output, things like that. Be watching for kidney toxicity. Also note that it must never be mixed with saline. We only mix this medication in D5W preparations. So nystatin is our other antifungal, and actually of the two, this is the one that you will deal with a lot in your nursing career if you work bedside at all, whether it's in acute setting, home health, long-term care. You're going to be giving nystatin. It's used to treat various types of candida infections. Typically it's given topically, but there are oral preparations for it as well. It's extremely toxic when used parenterally, and so we don't ever use it that way. Okay. It undergoes little to no absorption when used orally or topically. We use it to treat thrush, diaper rash, vaginal or vulvar candidiasis. I can't say that. Yeast, vaginal or yeast infections, or yeast that you'll find between the skin folds, under the breast, under the pannus, places like that. It could be in a cream. It might be a powder that you sprinkle on. It might be an oral preparation that they swish and swallow in their mouth. It might be a pill that they swallow. It might be a pill that they need to dissolve in their mouth. So what else do you need to know about nystatin? I do want to mention if it's in tablet form, they should, and it's used for the mouth, such as thrush or something, they should let that tablet dissolve in their mouth before swallowing, and that's so that the medication comes in contact with as much surface inside the mouth as possible. If it's a liquid preparation, they should swish and swallow that. It can cause some GI upset in some people, and if that's the case, then they should swish as long as they can and then spit it out. If not, swallowing that is better. We don't generally see it interact with any other medications in an adverse way, unless it's given in really high dosages. So that's really rare. It also could be given oral. Nystatin could be used to treat GI infections that are down in the gut. Okay, so metronidazole or Flagyl is an antiprotozoal. It is it also is a fairly broad antibacterial agent as well. Okay, it's the drug of choice for symptomatic intestinal disorders, and that would be things such as like Giardia or trichomoniasis or even pseudomembranous colitis. When I think of Flagyl, I think of C. diff. When I think of C. diff, I think of Flagyl and Vanco. Those would be your two. It's some things that you need to know about Flagyl. We won't talk a whole lot about it, but it does come in oral and parenteral forms, and it is absolutely contraindicated in the first pregnancy or trimester of pregnancy. Okay, and it also can be very dangerous if it's taken with alcohol. It interacts with alcohol. It really exponentiates the level of alcohol in the blood. Um, could be life-threatening. It has a few known, pretty common adverse side effects, and none of these would be reasons to stop the medication. It's just some patient education should be provided that your patient, don't be surprised if it causes a metallic taste in the mouth. It's not really pleasant, but it's not long lasting, or it can cause a lot of dryness in the mouth, and so you know, give your patient water if they can have it, or have them suck on some lozenges, something like that. And it is also known to cause nausea and headaches. That's not nearly as frequent as the dry mouth or the metallic taste, but it can happen. It's usually mild cases, and again, it's not something that we would stop the treatment for. Okay, so our anti-malarial drug treatment, it's not the same as TB treatment, but I want you to remember that also you should expect the patient to experience multi-drug therapy when they're being treated for malaria, and that's due to the life cycle of the protozoan parasite, which is really kind of icky to think about, but it goes through the mosquito as the first host and where the pregnancy occurs, and then they distribute it into the bloodstream of the human host, and then it goes through different phases within the human body, and different medications affect the different cycles, if that makes any sense to it. All you need to remember is that multi-drug therapy use for anti-malarial treatment is due to the life cycle of the protozoan parasite. Okay. Let's say we use it to treat an acute attack, which is usually what this chloroquine phosphate is used for. Just know that during that acute attack, the parasite will go down into the liver and will remain there. And typically we'll see the patient have a relapse, which would require a different medication, which would be part of that multi-drug therapy. We also use it prophylactically. We really recommend anybody that's going into a high risk area for malaria to be taking prophylactic treatment, which this chloroquine phosphate would be the drug of choice for prophylactic treatment as well. This is considered the most generally useful anti-malarial drug of the arsenal that we use there. It is used for mild to moderate acute attacks, and it rarely causes adverse effects. So we won't talk about this a whole lot, but I do want you to remember that your patient should understand that they should expect multi-drug therapy because of that life cycle. Okay, so some patient education that would go along with a lot of these last medications, your antifungals, your anti-malarial, or your TB drugs. They need to be reporting any weight gain, edema, or decreased urinary output. That would signal that we've got some renal dysfunction going on, right? They might experience some abdominal pain. Jaundice, especially with that rifampin, remember that can really affect their hepatic function and lead to jaundice, or what's the word, hepatitis problems. They should report if they don't have any improvement or if they experience worsening of their symptoms. Again, just like the antibacterials, they should take all of these medications exactly as prescribed, and they should finish their whole prescription. Don't stop taking it just because you feel better. Okay? We really want to stress the teaching of immunosuppression and the risk of fungal infections with any of these medications that we've talked about in these slides. Make sure that your patient understands how to assess for superinfection or, problems if they are experiencing immunosuppressant. What would that look like? Yeast in the mouth, fever, sores in the mouth, things like that. Um, Swish and swallow, that's pretty specific to your oral nystatin. Um, and continue topical preparations. So if they're taking a topical preparation, say it's nystatin cream and they're experiencing a vaginal yeast, they should continue taking that during their menstrual cycle. And if they're having sexual intercourse, they should be using a condom. Don't stop taking the medication, just use a condom during those episodes. Okay,